In this presentation, I will be demonstrating how to give a medication by the IV push route. Remember, IV push is a route by which we give undiluted IV medication directly into the bloodstream. It carries with it a very high risk for injury because the medication will take effect immediately. Remember, when giving IV push, before we push, we must act. And ACT is an acronym for the things that you must check before giving the medication by this route. A, is it appropriate for the IV push route? In other words, can it be given undiluted? A, and is it in accordance with your agency policy? There is a lot of policy surrounding IV push in the hospital setting. C, is it compatible? So when you're giving an IV push through the primary line, the IV push medication will share the same space with the primary fluids and any additives in the primary fluids, such as potassium chloride, for example. So we have to make sure that the medication is compatible with the primary fluids and any additives within it. And T, time. Over what amount of time do we need to administer the medication in order to give it safely? And there are no general times that apply to all IV push meds. It's very drug specific. So I would go into either an online database or my drug book and I would check for ACT. A, is it appropriate? So in this particular scenario, I'm going to be giving Toradol, which is ketorolac-tromethamine, the generic, to Mr. Tom Silver. And this is a pain medication that he's requested. And so I am going to look up the drug information for this drug, and I am going to see first and foremost, is it appropriate for the IV push route? So in my drug book, I see that it says may be given undiluted. And that tells me, that gives me the green light for IV push. I also have to make sure that I can give it in accordance with my policy. And it is not a problem in that regard. So C, compatibility. So I want to see if Toradol is compatible with D5 half normal saline, which happens to be the primary fluids in this instance. And there is a compatibility chart at the back of many drug books or hanging in the drug room. So you can first check the compatibility chart. And if it's not on the compatibility chart, you can look through your drug reference for compatibility information. And if you cannot find it, you can also call the pharmacy whenever in doubt. And then T, time. So I look for the administration time, and it tells me a single dose over a minimum of 15 seconds, evenly distributed over 1 to 2 minutes is preferred. So for Toradol, yes, it is appropriate for the IV push route. Yes, it is compatible with my primary fluids, and I need to give it over no less than 15 seconds, evenly distributed over 1 to 2 minutes is preferred. And so I will choose, and in this instance, I'm going to go ahead and give it over 1 minute. Okay, so I've done my homework, and now I'm ready to go ahead and get my drug from the med room. So in the med room, I would pull up the patient's chart, and then I would go ahead into the storage area, and I would pull my ketorolac-tromethamine. And I see I have a solution, 30 milligrams per milliliter. I'm doing my first check up against the EMAR, and I'm checking on Tom Silver that I have the right drug. The dose I will calculate by the IV push route. It is Q6 hours PRN, and so I see that he has not had a dose in the last 6 hours. And so I complete my first check. I'm also looking at the expiration, the manufacturer's expiration, and I see that it can also be given by the IV route, all on my labeling. Now I need to think about supplies, because I certainly don't want to be running in and out of the room. So what supplies do I need? In the NRL hospital, remember that we prepare next to the patient. So I need to take in a syringe and 30 milligrams per milliliter. I have a 30 milligram dose, so I'm going to take a 3 milliliter syringe, and then I am going to grab a red fill needle. I have alcohol pads in my pocket. If I needed tape for labeling, I could grab some tape. But in this instance, because I only have one injection, it is okay to use the vial as a means of labeling the syringe. If I had two look-alike syringes, then I would have to label them. Or alternatively, if I was prepping in the med room and then walking to the patient's room, I also must label. So with this, I am going to close the patient's chart and enter the patient's room. So now I'm in the patient's room. I'm washing my hands. When I enter the room, I'll greet the patient. I brought all my supplies in. Greet the patient, introduce myself, and let him know that I have his pain medication for him. And so I'll ask him, first things first, to state his name and date of birth. I'm going to pull up his chart, and he tells me his name is Tom Silver. It gives me his date of birth, and then I also check allergies at this time. So he's confirming allergies, that he's allergic to bee stings. I make sure that I check his wristband up against the chart, so making sure that I'm looking back and forth and listening to his verbal statement as well. And so at this point in time, once I have checked identifiers, then I'm going to go ahead and I'm going to do my second check on the medication. So I will go ahead and pull up the EMR, and from there I'm going to go ahead and check drug, dose, route, time. In this case we have a frequency because it is PRN. Documentation will come into place with my scanning, and then reason, he is telling me that he is in pain and this is a pain medication, so this does make sense for him. So now I'm ready to prepare the medication, so I'm going to wash my hands and put on some gloves. Okay, so I'm going to begin by scrubbing the top of my vial for 15 seconds. So I am going to use a good bit of friction. Make sure I scrub that down. And while that's drying, I'm going to go ahead and assemble my needle and syringe. My med math is very straightforward here, 30 milligrams per milliliter, and I have a 30 milligram dose. So I know that I will be pulling up 1 milliliter, air first, and then withdraw your 1 milliliter. Okay, I have 1 ml. I scoop up my cap, and now I need to do check 3. Back to the EMR. Tom Silver, drug, my Toradol, dose 30 milligrams, 30 milligram in 1 milliliter. I have 1 milliliter prepared. My route is IV push. My time, Q6 hours PRN. He has not received it in the last 6. And then I know documentation will come with scanning, which I'll do next, and reason, he is complaining of pain. So then, after I have done check 3, I go ahead and scan it in, press administer, I scan the wristband, and then I scan the medication. Okay. And then with that, I take a moment of pause, and I'm just going to run through my checks and balances. I have two I checked as identifiers, 2 unique identifiers, allergies, 3 checks of the medication against the EMAR. I scanned everything in, and then with regard to IV push, yes, it's appropriate, yes, it's compatible, and I have a 1-minute time over which to push. Now, the other thing I like to do before I get started is I like to have a game plan, meaning that when I'm pushing an IV push medication, it is not a continuous sustained push. It really amounts to a series of small pushes or incremental pushes where I'm giving a little bit of the medication approximately every 15 seconds. So when I'm looking at the volume that I have to give, and then considering the safe time over which to give it, I like to divide up my volume so I know how much I want to give incrementally. So if I give a small amount every 15 seconds, I know with 1 milliliter volume, I will give about 1/4 of a milliliter every 15 seconds. Okay, so I have a game plan. I know how much I'm going to push incrementally. So now I'm ready to go ahead and administer my Toradol. In this instance, when we're going through the primary line, there's no need for any flushes. The only time that we need a flush, because really with the primary fluid that's compatible, that is serving as a pre-flush and a post-flush. That's transporting the medication into the bloodstream as I'm pushing it, so no need for flushes. The only time I need a flush is when I have an incompatibility or when I have a very small volume of medication, and a small volume of medication is classified as 0.5 milliliters or less, or when I have a very slow primary rate, and that would be a rate of 50 milliliters per hour or less. In those cases, we would use a flush, but in this case, there's no need for any saline flushes, so I will have just my medication here. So I begin by scrubbing the Y site closest to the patient, and this is where our IV pushes will go. So we do a 15-second scrub. Okay, and then once we do that, we're going to take off that fill needle, and that will go into the sharps container, and we're going to push and twist to attach our medication to the Y site. We don't want to turn the pump off. We want it to be running again so the flow is transporting the medication into the bloodstream. But we do begin by pinching the tubing just above the Y site, and we begin by aspirating. So we're pulling back on the plunger, and we're looking for a little flash of blood in our saline lock here to reassure us that this is in fact going into the bloodstream, that this is a good IV, that we're not on the front end of an infiltration or something along those lines. So we pinch our tubing just above the Y site, we aspirate. We see a nice flash of blood. So now, looking at the second hand of our watch, we're going to go ahead and we're going to give the first increment, which, remember, in this instance is 1/4 of a milliliter. So we push in 1/4 of a mil, and now we're going to release the tubing, and we're going to wait 15 seconds. Now the pump, you'll hear, is alarming, and that's simply because I'm pinching the tubing and it's picking up a downstream occlusion. So just don't worry about that. And when you release the pinch, it'll stop alarming. And if the pump should turn itself off, make sure that you turn it back on, because again, we need the flow to bring the medication into the bloodstream. So 15 seconds has passed. So again, I pinch, I push the next increment the next 1/4 mil, and then I release the tubing, and then I will pause for 15 seconds before pushing the next increment. Pinch, push, release. And you'll notice that you'll notice there is a pattern. I'm going to pinch the tubing, push the incremental amount, release the tubing so that it starts to flow into the patient, and wait the balance of the 15 seconds. So pinch, push, release, pause. And we do that incrementally until the medication has been delivered. At this point, we're going to get rid of our needle and syringe in the sharps container. Certainly, we're monitoring our patient very closely because, again, this is going to have an immediate effect. So we'll make sure there's no adverse effect or allergic response to this as we're giving it. But after you've given the medication, then the primary fluids will continue to flow, and we will just put our patient in a position of comfort and safety and keep a close eye on the patient, and that completes the administration of the IV push Toradol.